Welcome everyone to the Tier 3 workshop discussion session. I just want to remind everybody to ensure that your microphones are muted, and when it comes to asking questions and stuff, you have three options. You can put your question in the chat or in the Q&A function of Teams, or you can raise your hand and we will be able to get you in sequential order. And at that time, you can unmute your microphones to ask your question. I would like to introduce Dr. Jonathan Mack, who is a physician here at the Ottawa Hospital through ERLA, as well as a medical officer with the Canadian Blood Services, who was very instrumental in putting all three workshops together for you guys to do. With that, I will hand it over to Dr. Mack to discuss the Tier 3.
Thank you very much, Tracy. Just to check, everyone can see the slides okay?
Yeah.
Excellent. And apologies to anyone who's been here for Tiers 1 and Tier 2 to be kind of a broken record, but there are people who are only participating in Tier 3, and I don't want to leave recognition where it's deserved kind of silent. So big thank you to people who've helped put together the workshop for today, which include Tracy Cameron, Valerie Rayom, and Sheena Showerman from the ORBCoN side, who've helped with making sure that we had the infrastructure for registrations and communications back and forth, keeping track of who's registered, etc. And then on the neural side and CBS side, question development, sample preparation, boxing up and shipping out all the samples from Jackie Cote, Tammy Eisen, Lise Kemp, Carmela Pote, and Tony Lin. I mentioned in the last session, but there's just, I think 65 or 67 samples total that went out for just Tier 1 alone. And so tremendous amount of work that particularly Lise put in packing up boxes and making sure the shipping was arranged and everything else. Really a lot of work that went into that. So big thank you, and hopefully we can continue with these wet workshops into the future. And as we learn from the experiences this year, as this is one of the first wet workshops we've done in a while, and certainly the first one I've been involved in participating in, kind of learn from how it worked and make them better and better as time goes on. So format for this afternoon will be like the last two tiers. You were sent the samples for testing. We'll go through some of the questions that are related to what we were, what you were seeing and what we were expecting you to see. And then there's a series of questions which you'd answered online. We'll go through each question one by one and a bit of a discussion around the ones where there might have been some different answers and some of the rationale behind what we were expecting. So just as a reminder for the case 1, which was the case you had the sample for, this was a 56-year-old male patient who's admitted with septic shock due to pneumonia. We have a historical ABO type that's group O, and he's given a platelet and plasma transfusions for suspected DIC, disseminated intravascular coagulation, which can be seen in sepsis. He's given the group A platelets and 2 units of AB plasma. Platelets given over 20 minutes without any events, and then about 30 minutes into the first unit of plasma, he developed some rigors and fever, and so a transfusion reaction sample was collected, and that's what we were providing you with as part of the workshop. So just in terms of information from the case that's relevant and worth highlighting, it's a 56-year-old person, they're male, and they're in septic shock. So the septic shock kind of has some relevance potentially for some things that could impact the blood typing. We've got historical ABO typing that is group O, and it's platelet and plasma transfusions, but no red cell containing products that were transfused. The platelets were group A platelets, but given he's group O, there aren't really any concerns about incompatibility from an ABO point of view, and it's AB plasma that was issued, so really not a lot to be worried about from an AB anti-A, anti-B antibody that would be relevant for this group O patient. And it's about 30 minutes after the plasma started that he gets rigors and fever. So those are sort of the reaction symptoms. So relatively broad differential in terms of, transfusion reactions that might be explained by the rigors and fever. So the first question we asked here was, what investigation is least likely to be helpful in the investigation of this transfusion reaction? What should we be? What isn't going to help us here? And our options being a clerical check, double checking our pre and post samples and the labels, making sure there weren't any mix-ups happening there. Direct antiglobulin testing. Should have mentioned in the question some of this would have been on the post transfusion sample. Confirmation of ABO typing on the post transfusion sample, or repeating the antibody screening, again meant to be on the post transfusion sample. In terms of responses, we got a bit of a split between the blue clerical check being least helpful, and repeating antibody screening the most popular, 21 people answering that. Suggested answer here is repeating the antibody screening is probably not going to be very helpful, or is going to be the least helpful of all the testing that's there. Rationale behind that, I guess just going through answer by answer, the clerical check is really going to be pretty important. And if we're worried about there being a potential hemolytic reaction that might have happened, it'd be from it's a plasma containing products that he got. So A plasma, AB plasma. We think he's a group O patient, but is this really the right patient that we're transfusing? We don't really know. So the clerical check is going to be important to make sure that all those things line up. And historically, we know from shot data that out of the UK that clerical errors are the most common cause of acute hemolytic reactions nowadays. So that would be one of the most helpful things to do, not the least likely. And in terms of the other two tests, direct antiglobulin testing would be helpful if we think there might be some antibodies that were in the patient, the transfused plasma, that might have reacted with his red cells, or if there were some concerns about mixing up the ABO typing on the patient that we thought we transfused. We were told he's historically group O and presumably we're transfused according to that. But maybe we mixed up the sample and this isn't the right patient, so that testing is going to be helpful. Repeat antibody screening is probably not going to be all that helpful in this case, and the rationale for that is that this is a plasma transfused patient, so plasma and platelets. Really didn't get any red cells, and so his antibodies in his plasma aren't going to be all that relevant for whatever reaction happened. There aren't going to be that many transfused red cells aside from the small amount that might contaminate the platelet product. So in terms of sort of helpful tests, repeating the antibody screening, if we screwed up the antibody screen, that's probably not going to have a lot of relevance for a reaction related to plasma or platelets. Next question was, which of the following is least likely following an episode of acute intravascular hemolysis? Our options being dark or icteric urine, albuminuria, an increased LDH or lactate dehydrogenase. Some hospitals call that LD, a negative DAT, or spherocytes. The options here, most people answering a negative DAT, followed by presence of spherocytes, going to be least likely. No one answering dark or icteric urine, thankfully, and increased LDH, only one answer for that one. So in terms of what's least likely, suggested answer here would be the spherocytes. Rationale behind this one is, why do spherocytes develop? So spherocytes occur because of red cells that have had IgG stuck to them, and then the IgG gets removed in the reticuloendothelial system, usually in the spleen, and that removes part of the membrane with it. So the red cell no longer has as much red cell membrane to hold that nice biconcave donut shape, and so becomes a sphere. And so that's dependent on IgG coating of the RBC membrane. And if we're looking at an acute intravascular hemolysis reaction, that's usually going to be complement mediated to cause intravascular hemolysis, whereas IgGs are going to be more extravascular hemolysis. So if we're seeing spherocytes, spherocytes are not really going to be all that common if we're seeing acute intravascular hemolysis. Negative DAT is a reasonable option, I think, there, but important to remember, and the reason why that was put in as a bit of a red herring is that the DAT is a negative DAT really doesn't exclude hemolytic transfusion reaction, and depending on how much red cells were transfused and how aggressive the hemolysis is, a negative DAT actually might be seen fairly frequently with acute hemolytic reactions because it relies on you having transfused cells that have the antibody stuck to them. And if you've hemolyzed all the cells that were transfused, or if very few cells were transfused, your DAT might be negative. So not something that's going to be necessarily less likely than the spherocytes being present. And obviously A and B are sort of expected findings regardless of the type of hemolysis that's happening there. And you'd really expect to see that for acute intravascular hemolysis. So that's where D was the suggested answer. So getting into what people were getting on their typing, we wanted to see on this sample what were people getting for their forward ABO typing. And a bit of a mix here. About a third of people got group O as their response, and you can see in the word map here of other responses that were provided. Some that made sense, but some that didn't quite make sense with the ABO typing. The expected answer that we had here would have been an AB typing, or might have seen some invalid due to mixed field with anti-A and anti-B. So that was what we were expecting people to get with the front typing. On the reverse ABO typing, 20% of people got group O, with, again, sort of a mix of answers there, some that are decipherable and others that are not. What we were expecting for this one was group O, so good on you, the people who got the group O. On the DAT results, for those of you that had done them, what we were expecting, what we got as answers, about 51% answered positive for this question, with a bit of a mix of other responses. What we were expecting was an invalid result due to a positive saline control. So I guess for the labs that don't include the positive saline control as a matter of routine, we were expecting you to see a positive reaction on the C3 at least. But should be interpreted as invalid because of the positive saline control. But if you weren't doing the positive saline control, then you might have interpreted as being positive. And then on antibody screening, results that we saw here was about 89% of people getting negative results. I'm not sure what to make of some of the other answers that were just IgG, some other answers like that. And that was the expected result, was that the antibody screen was going to be negative in this case. So what these cells were that we provided were group O red cells that had been neuraminidase treated, given away the answers for a couple questions down the road, but just explain the context of this. So we're trying to recreate a polyagglutination syndrome sample. So that's where we were expecting to see the back type being group O, which is what most people got. And on the front type, depending on the reagents you're using, you might have seen AB, or it might have been some mixed field, again, because of the polyagglutination causing some exposure advantages that we expect to react with most of the AB, anti-A, and anti-B reagents that are being used. So that's where those answers are coming from. It's kind of explaining that. The DAT, the positive saline control, because the samples were shipped on plasma, we would anticipate that the naturally occurring antibodies in the plasma of the patient would then be coating those red cells following the neuraminidase treatment. But they should be clumping together with those IgM antibodies in the test tube. And so that's where the positive saline control was what we were expecting people to see. And the antibody screen should be negative. The sample that we were using, the plasma, was negative for any antibodies. And so that's where kind of explaining what we're expecting and what you should have seen. So in terms of interpreting the samples, again, expecting people to see either an AB or a mixed field on the front type and a group O on the back type. The answer here to what is the ABO interpretation, what we were expecting was impossible to determine. 15 people got that. Quite a few people got group O only. So not sure kind of what explains that, unless you weren't picking up the AB or the mixed field on the front typing. But within for our controls on it, the neuraminidase was pretty effective at causing that interference. So impossible to determine was the correct answer here. In terms of the most likely cause of the typing results observed, gave it away with the earlier discussion. The answer here was that we're expecting was a polyagglutination syndrome, which most people got. In terms of rationale or why some of the answers wouldn't be great, the drug-dependent autoantibody, if we're looking at the expected results being mixed, sort of ABO discrepancy on the ABO typing, a negative antibody screen, and an uninterpretable, for generous, say maybe a positive DAT result, that wouldn't be what we expect from a drug-dependent autoantibody. That shouldn't cause an ABO discrepancy, would cause a negative antibody screen, and then should cause a positive DAT, but not expecting a positive saline control with that one. Hypergammaglobulinemia causing rouleau, we might expect an ABO discrepancy from that if we're seeing some mixed field on the front typing, but would expect that to cause maybe some agglutination or panagglutination on the antibody screen, and then a negative DAT. And recent treatment with daratumumab, so daratumumab being an anti-CD38, which is expressed on all red cells, we'd expect no ABO discrepancies with daratumumab treatment, a panagglutination on the antibody screen, and then depending on how long the patient had been being treated, a positive or a negative DAT. So again, not totally fitting there because of the expected panagglutination, and we're not seeing that in our sample. So polyagglutination syndrome would fit here with there being no ABO discrepancy, an ABO discrepancy, a negative antibody screen, and either a positive or negative DAT being described in different cases of polyagglutination. So question X was, which of the following is true regarding transfusion of the patient from whom the sample was taken? So again, this sample with polyagglutination. So finding compatible red cells will be a challenge. HLA antibodies most likely cause the reaction. Plasma or platelet transfusion may result in an intravascular hemolytic reaction, or AV plasma or platelets will be safe even if the ABO typing is not confirmed. So in terms of responses we got here, most people got the right answer here, which was plasma or platelet transfusion may result in an intravascular hemolytic reaction. Just take a minute to go through acquired polyagglutination syndrome, which is what this case was meant to represent. It's a patient who's admitted with a pneumonia, so has an infection, and following the transfusion of that plasma, that was, we're hoping you got that would have caused the hemolytic reaction that we're trying to tease out. So what is acquired polyagglutination syndrome? So it's a phenomenon that occurs where RBCs from the patient that has the syndrome are agglutinated by nearly all human sera. So no matter what you're testing the RBCs with, that's human sera, you'll get reactions and activation from it, except cord plasma. And that has to do with what's happening in polyagglutination syndrome. These syndromes occur because of, in the acquired form, which are associated with both infections and some types of malignancies, myelodysplasia being one and leukemia being another. You get the exposure of these cryptic antigens that normally aren't exposed on the surface of the red blood cell. So if you look at the figure on the right, you have this T antigen as an example, one of them that normally is covered by this N-acetylneuraminidinic acid. And so we don't actually see that, from a plasma point of view on the red cell surface. And in the setting of infections or with some of these malignancies, there are enzymes produced by the infectious agent, so the bacteria or whatever microbe is causing the infection, that cleave, for example, the T antigen will cleave off these acetyl groups, and that results in the exposure of this T antigen that we wouldn't otherwise see. And where that causes the challenges in the blood bank is that a lot of these cryptic antigens we have naturally occurring antibodies against. So very much like the ABO system, if we have exposure to, if you're group A, we get exposure to B-like substances on microbes through our diet, we'll make anti-B antibodies. And these T antigens and cousins of the T antigen are also expressed on, we think, on microbes. And so we get the same kind of sensitization against them. They just don't have much relevance in blood banking world for routine patients because we're not seeing those antigens on the red cells. And so in these patients who develop the polyagglutination syndrome due to infection or malignancy, the exposure of those antigens now leads to a problem with their red cells. And if they're transfused plasma from regular patients who have these T antibodies circulating and they're in their plasma, that can then lead to a hemolytic type reaction with the plasma transfusion and a lot of agglutination reactions occurring in the blood bank when we're phenotyping and working with the red cells of the patient specifically. Again, just to emphasize that the problem is with the recipient RBCs and not the donor RBCs. It's a recipient kind of problem, the patient problem. So that's just a bit about polyagglutination and kind of explaining why we're seeing what we're expecting to see. There's a bunch of different antigens that have been described that have been involved in acquired polyagglutination syndrome. So T, TH, TK, TN, and TX. There's also some other congenital forms that infants who are born with deficiencies in how they create sialic acid residues on the outside of the red cells. So kind of a complicated and rare syndrome. Just a bit of an overview of it. So with that in mind, when you ask the question of what's true regarding transfusion, well, it's the plasma or platelet transfusions that we'd be worried about causing an intravascular reaction because of the T antigen or cryptic antigen exposure. We're not really worried about, in this particular patient, finding compatible red cells. We don't expect it's going to be a challenge because, again, it's not a problem with the patient's plasma causing a problem with transfused red cells. It's the inverse. It's the patient's red cells being incompatible with any transfused plasma. HLA antibodies, we don't think are really likely to have caused a reaction here. We don't have a very strong transfusion history. And given the serology findings in the samples that were provided, that would be kind of weird to see if this was just an HLA antibody problem. We shouldn't really see any sort of funniness with the ABO typing or with the DAT. And in terms of AB plasma or platelets being safe, again, because of the antigen exposure, the cryptantigen exposure on the patient's red cells, even if we're giving ABO type platelet or plasma, which are AB plasma, that's going to have anti-T or anti-T-like antibodies in it that could cause a hemolytic type reaction in this patient. So that's why that's not a great answer. In terms of what leads to exposure of T antigens in RBC membrane, so covered this a little bit in the discussion of polyagglutination syndrome. Answers here were neuraminidase produced by bacteria, removing the N-acetyl neuramidic acid, antibiotic administration, congenital enzyme deficiencies leading to poor branching, or T antigens are actually normally detectable on the outside of RBCs. And so everyone here, most everyone got the right answer here, which is that neuraminidase produced by the bacteria removes that N-acetyl group. Next question was, what is the risk of transfusing the patient that provided the sample? In delayed hemolytic reaction from undetected RBC antibodies, increased risk of TRALI in the context of infection, recipient anti-T antibodies leading to hemolysis of transfused RBCs, naturally occurring donor anti-T antibodies causing severe intravascular hemolysis. In terms of answers here, most everybody got the right answer here with naturally occurring anti-T antibodies causing intravascular hemolysis from the donor. Few people answering the recipient T antibodies. So again, just to emphasize that the problem here is with the RBCs of the donor or the recipient, the patient getting the plasma, not the donor RBCs. So it's not the anti-T antibodies in the patient causing hemolysis of transfused RBCs, because any transfused RBCs won't have that cryptantigen exposure. It's the antigen exposure on the recipient RBCs, the patient's RBCs, that are prone to hemolysis from the anti-T and transfused plasma. That's for that one, the suggested answer. Next question was, which of the following is most likely helpful in confirming the suspected diagnosis? So we have a bunch of weird sounding things here: Arachis hypogaea, glycine soya, Leonoris cardiaca, or AB plasma serum. These are all examples of, it's the first three examples of some lectins that are commonly used in panels to diagnose polyagglutination syndrome. And answers here, about 20 people answering Arachis hypogaea, AB plasma serum by 10, and then a few people between the other two answers. So favorite answer here is answer A, which most people got right. So it's Arachis hypogaea. It's a bit of a, it's a fictitious question here because we're never going to use just one lectin in working up polyagglutination syndrome, but there'll be panels of lectins that are used to try and tease out the different T antigens that might be exposed. But in terms of why the answer for this question is A, if we look at some of the reactivity that we expect with the common acquired polyagglutination types, we have T, TH, TK, TN, and TX. And all of them except for TN are associated with infection, which this patient was admitted with. The TN polyagglutination is associated more with malignancies. And if we look across the top, AB plasma is not going to be all that useful because it's going to be reactive with everybody, so it's not really going to help us differentiate too much. Arachis hypogaea is going to be reactive with most except for the TN. And glycine soya is only going to be reactive with a couple types, including the TN, but not most of the other types of the TH, TK, or the TX. So it's not really going to help us much, as much as Arachis hypogea if we're seeing reactivity with it. And Leonoris cardiaca really wouldn't react with any of these, so it would actually give us the impression that there wasn't any polyglutination. So that's why Arachis hypogea is the favorite answer here. Next question was, which of the following statements is true regarding this patient? So are red cells in inventory high risk of hemolysis, even if cross-match compatible? Or red cells in routine inventory are low risk of hemolysis if cross-match compatible? Red cells in routine inventory should not be used unless we actually type them for their T antigen, or we should have family members considered for directed donation. So again, with the reminder that the problem is with the patient's red cells and not anything to do with the patient's plasma. Favorite answer here would be B, that the red cells in routine inventory are low risk. And I think this was what most people got. 21 people, the few people kind of split among the other answers. Again, going through the one by one, the red cells in routine inventory, if you transfuse them, the patients, those red cells aren't going to have any risk of hemolysis because they don't have the TN or the T exposure. So not a concern of hemolysis with them. We don't worry about the typing of the T antigen on those red cells. We're not expecting them to be T positive or detectably T positive. So no need to do that. And it's not really a question of family members being needed to be considered because it's an acquired problem. So it's nothing to do with antigen expression that's kind of genetically driven. It's a normally expressed antigen. It's just hidden and has nothing to do with any inheritance, at least in this particular situation. So that's why D is not a great answer either. And next question, which I think is getting towards the end of the questions, is the HLA antibody testing is performed, just given the suspicion that maybe this was a reaction with the HLA, with the platelets and HLA mediated cause of the fevers and rigors, and a poor response to platelet transfusion. So which of the following statements is true regarding HLA antibody testing? One is HLA antibodies are only relevant for transplant matching. We don't really care about them otherwise. HLA antibodies may cause decreased survival of transfused red cells. HLA antibodies may cause decreased survival of transfused platelets, or both B and C. And we had a split here between antibodies being only relevant for the platelets, or both platelets and red cells. So the favorite answer here, it's both B and C. So just a reminder that HLA class 1 is expressed on platelets. But some HLA is also expressed on red cells and is absorbed onto the red cell and we call those the BG antibodies or BG antigens, sorry. So BGA, BGB, and BGC are actually examples of HLA that's being absorbed onto the red cell. And so they can, it's not common, but there are described cases of patients with anti-BG antibodies who, when transfused to corresponding BG antigen, have a hemolytic reaction of those red cells. So they can be relevant for red cell survival. And HLA antibodies are, pretty well recognized. Most people are familiar with the complications of platelet refractoriness that HLA sensitized individuals can have, where the transfused platelets, because of the HLA expression, just don't live as long, and so you'll get almost no increment in the platelet count following transfusion of an incompatible platelet, but usually not a lot of clinical reactions, occasionally low-grade fevers or rigors that can occur with it, but not usually a very dramatic reaction with the platelet transfusion. So that the end of that case. Case 2 is didn't have a sample for. We had tried our best, but unfortunately, we're getting had some challenges, I think, with the sample controls working. So we didn't want to risk sending it out and having people be very confused with it. So it was just more of a dry style workshop for this case. It was a 72-year-old patient, history of orthopedic surgery following a fall from a ladder while picking apples with her granddaughter. This antibody screening in a panel with Fison-treated red cells were shown or were provided. Before we get into the panel, just a few things to mention here is that it's a 78-year-old patient. We don't know their gender, and they've got a history of orthopedic surgery, so potential transfusion exposure. We know they've got a granddaughter, so they've had kids, potentially if they're a female. This was the panel that was presented. And the question was, what antigen specificities are present? So if we go through with our rule outs, with everything provided between the immediate spin and the IAT results, we can rule out everything except for the antigens indicated in blue. B and LUA for this particular scenario wouldn't explain a lot of the reactivity because none of the cells actually had either of those on them, aside from cell 3 for the LUA. Which one was it? I'm sorry, it's KPB and JSA what I was thinking of. So those ones, none of them are expressed. I wouldn't explain the reactivity that we're seeing. But we can't rule out an F, little f. We can't rule out the Lutheran A. And it looks in here like we can confirm the anti-little c and an anti-XGA reactivity. The question we had was, what are the specificities? With about 70% of people answering just the anti-C alone. Some mix between anti-C, anti-little c, and anti-XGA, and some with just the anti-XGA being reported. In terms of specificities that cannot be excluded, so the expected answer here was little f and LUA. We did have some answers here, 19% with anti-big E, but we did have the one homozygous exclusion for anti-big E that was there. So our suggested answers here was anti-little f and anti-LUA. The question was, based on the antibody specificities, which of the following is most likely? So we've got the anti-little c and the anti-XGA that were confirmed. Options being the patient has Hawaiian ancestry, patient's a grandmother, the patient's a grandfather, or the patient has a movement disorder and acanthocytes will be present. In terms of responses, here was a bit of a mix across the board. Expected answer here, suggested answer here is answer C, that the patient is a grandfather, being most likely. Rationale behind this, if we go through A and D, A, Hawaiian ancestry is getting at JK3, so we know that population is a population that has a higher frequency of being JK3 null. So not explained or not fitting with the patient having an XGA and an anti-little c antibodies. Answer D is getting at the McLeod phenotype. This is a clinical syndrome that's observed in patients who are lacking the KX or KM antigens on their red cells. So they can develop this choreiform movement disorder, and you look at their blood film, they have a lot of acanthocytes, very spiculated kind of looking red cells. So those are sort of KEL related things, so not explaining an XGA antibody or a little c. And then between the patient being a grandmother and a grandfather, 11.3% of females are XGA negative, but 34.4% of males are XGA negative. So it's XGA has to do with the fact that it's an X-linked expression. So because it's more likely that a male is going to be XGA negative than a female, we're sort of led to believe that the patient's more likely to be a grandfather than a grandmother. So that's the answer for that one. Next question is, which of the following patterns would be expected if the screen and panel cells were treated with DTT? So either all reactions would become negative, some of the reactions would become negative, but some would stay the same. Reactivity would be identical to the IAT results without Fison, or stronger reactivity would be observed for all positive reactions. So suggested answer here in terms of the responses. Apologies, it's cut off here, but most people answering that the reactivity would be identical to the IAT results without Fison. Some people thinking that they would become negative, some would become negative, and some would stay the same. Suggested answer here would be that they would be identical to the IAT results without Fison. That's because the XGA is DTT resistant, so wouldn't be affected by DTT. The little c is also DTT resistant, and little f is DTT resistant, so DTT really shouldn't change the reactivity we're seeing with any of these. The IAT results, we weren't seeing a lot of the XGA reactivity there, so it's primarily the little c and can't exclude the little f, which shouldn't be affected by DTT at all. So C is the suggested answer there. There's the clinical relevance of the serologic findings. What do we expect? So the identified antibodies are all capable of causing HDFN. Delayed hemolytic reactions are very common with all of them. Transfusion of incompatible red cells is very likely to cause a hemolytic reaction, or the antibodies have not been demonstrated to have any clinical significance. significance. And again, we're referring to the anti-little c and the anti-XGA here. Sorry for why these are cut off. I think the green was the most commonly answered reaction, which is that transfusion of incompatible red cells is likely to cause a hemolytic reaction, and that was the favored answer. Anti-little c and anti-little f are both associated with hemolytic transfusion reactions and HDFN. Anti-XGA is not. But if we think about incompatible red cells, with anti-little c being a fairly commonly expressed antigen, if you're going to have an incompatible red cell, there's a reasonably good chance it's going to be little c because of a little c antibody or a little c antigen. And so that could cause a hemolytic reaction because of that association. So that makes C the favored answer in this case. The patient's plasma is showing BGA specificity. This is a patient's plasma. We're moving away from the case here. The question is, which of the following is true? The patient's likely negative for HLA-B17. BGA positive RBCs treated with EGA, EDTA glycine will not react with the plasma. Weak reactivity is expected that will persist even with very dilute plasma. Transfused platelets may have reduced survival, or both B and D. In terms of responses here, most everybody got the right answer here, which is both B and D. Rationale for this is the patients with a BGA antibody, we can't really conclude much about the B17. The BGA is HLA-B7, so if they made a BGA antibody, then we can conclude they have to be BGA HLA-B7 negative, but can't really conclude much about the HLA-B17 antigen. EGA treatment is effective at removing a BG antibody, so EGA will remove BG. So if we treat HLA positive cells with EGA, we should remove any HLA antibody reactivity. It also will affect KEL, ER, and JK blood groups, the EGA treatment. Weak reactivity that persists with very dilute plasma is, it's kind of describing an HTLA like behavior, which is not a BGA or an HLA antibody that's seen with Chido, Rogers, Costerling, Knops, York, Boy, and JMH. So BGA not included in the list of HTLA-like behavior. And obviously, if the patient has an HLA antibody, as we covered in one of the other questions, it doesn't have relevance only for red cells, but platelets are much more likely to be problematic. And if you transfuse a platelet expressing the corresponding HLA, a B7 antigen, then those may get cleared by that antibody. So D is also correct, making E the favorite answer here. So I think with that, that's all the questions I had. I'll stop there and thank everybody again for their attention. And if there's any questions that you haven't asked yet, or clarifications you want, or disagreements, please feel free to put them in the chat, the Q&A, or put up your hand and we can have a discussion.
Give a minute or two for those that may be typing in their question. Don't be shy. You guys can put in your questions or raise your hand. Well, I guess we can wrap things up then if you want, Dr. Mack.
Sounds good to me. Yeah, I mean, I think if there are any questions that come up afterwards, please feel free to email us. I think most people have Tracy's email, and then she can forward the questions on to me. And again, I'd just like to thank everybody on the ORBCoN and CBS and Neuroscience for helping to put the workshop together. Hopefully, it was a valuable experience for all the participants. And as I mentioned with some of the prior tiers, first time doing the wet workshop in a while. So some learning experiences on our end about how to smoothly do things, and learning points for the future that we'll hope to build on, and make this a valuable learning experience for everyone that participates.
All right. And just to let everybody know that you will receive a certificate for attending this, plus any other discussion sessions that we had this afternoon, plus the time that you had for doing the actual work, the workups for each of the tiers. And that will probably be sent out to you later on next week, because you can appreciate that we have to kind of culminate everybody's hours and kind of individually send out your certificates. So just bear with us for the next couple of days while we work on getting that sent out to you. And yes, all three of the discussion sessions have been recorded, and we will upload them to our website for you guys to watch anytime you want. And I think that's kind of it. So again, thank you very much. Thank you very much, Dr. Mack, for putting on these sessions for us, and actually providing the samples and that for everyone to complete the workshop.
Thank you. Thanks for all your help, Tracy.
All right, and hopefully we see most of you tomorrow for the 19th annual transfusion medicine education symposium. So, all right, have a great night, everybody.